Okay, guys, we're going to talk about splanchnic artery aneurysms now, okay? The aneurysms in general are abnormal full thickness bulging of the vessels, secondary to localized weakness, defect, or trauma. When we're talking about splanchnic artery vessels, or aneurysms rather, we fall into these kind of categories here. So we're going to discuss the splenic aneurysms, the hepatic aneurysms, SMA and IMA, celiac excess renal artery aneurysms. Together, these are all, again, called the splanchnic artery aneurysms. Let's start with the splenic aneurysms. So splenic artery aneurysms are the most common splanchnic aneurysms, so 60% of those. That said, they're still pretty rare. So the incidence is actually 0.78%. So let's say less than 0.1%, or 1 out of 1,000, less than 1 out of 1,000 at autopsy. 4 times more females are affected than males. 24 or 25% mortality if it ruptures. Now here's the key. If it ruptured during pregnancy, it's 80% mortality, maternal mortality, and that's 90% fetal mortality, okay? Splanchnic artery aneurysms, the greatest risk factors are obviously female gender and multiparous females, because once it's there, so it develops during pregnancy and then it stays. And then portal hypertension. The majority are incidentally diagnosed. This is a question I got on oral boards, and you may too, which is what happens when you have a signet ring calcification with the left upper quadrant on an X-ray. You call that a splenic artery aneurysm. The blood and the blood turbulence there causes a calcification, and as well as that disrupted intima. A couple modalities are good for surveillance, so ultrasonography. So this is if you find them and you don't want to intervene. And we'll talk about when you don't intervene, but if you find them and you don't intervene, you can do ultrasonography, CT or CTA, and then MRI or RCP. So we're going to talk about when you just obviously have to intervene and then when you can intervene. So you have to intervene if it ruptures, right? And there's a characteristic pain which is called the double rupture pain. It's almost pathognomonic for this. And I say almost because we're going to talk about in a second the only other situation that you'll encounter this in. The double rupture is again, a near pathognomonic term, and it applies to when you have left upper quadrant or epigastric pain. Immediately post-rupture, the blood will was initially contained by and painfully distending the lesser sac. But then the caustic blood began to accumulate within the peritoneum itself, so it ruptured through the sac and it accumulates within the peritoneum itself, hearkening the onset of a global wave of pain and peritonitis. So you have initially the pain of that distended sac, then it's relieved as it ruptures, and then it comes back again as it becomes peritonitis. So when do you intervene on an incidental splenic artery aneurysm? Well, operate now. If the patient's pregnant or of childbearing age, now's the time. Otherwise, you operate when it reaches 2 centimeters. That 2 centimeters is a good number to know for a number of things that we're going to talk about today. How to intervene. So first when, and then how to. So when is when a person's pregnant or it's over 2 centimeters. How to do so? Options include simple ligation of it, so essentially stapling across or clipping across it, excision of it itself and putting a dictaphone graft in, endovascular stenting, or a splenectomy. That used to be the answer. Splenectomy used to be the answer, but it's no longer the answer. It's now one of these options. So we'll move on to hepatic artery aneurysms. Hepatic artery aneurysms are the second most common. In fact, these are ranked in order, so if you remember the order, you'll remember the most common to least common. Most common, second most common is, again, these hepatic artery aneurysms represent 20% of all splanchnic aneurysms, usually discovered incidentally. You do immediately repair those that are symptomatic, or if there's a pseudoaneurysm suspected, and you say, well, when would I suspect that? We suspect that when there's been instrumentation there, and the instrumentation may in fact be the problem, or may have catalyzed this. So this would be, something like you're getting some sort of, tips or something else, or I don't know, maybe they wouldn't be a regular candidate, but some sort of instrumentation up there, and as a result of that, they developed this new aneurysm, which is presumed to be instrumentation associated or iatrogenic in nature. Otherwise, you only intervene when they're 2 centimeters in diameter or greater, so the same as splenic arteries. If it's now, what do you do about it? If it's the common hepatic artery, you can ligate. If it's on the common hepatic artery, you can ligate. You can do an open aneurysmorraphy, which is essentially where you sort of cut it out, create a flap out of what you have left, and then you kind of close it down, so it's a primary closure. Or you can do an aneurysmectomy, which is where you cut out the aneurysm and you put a Descartes graft or some sort of graft in there. And then there's endovascular exclusion via stent, and that's probably preferred these days, is just to use a covered stent and slide it on through there and make sure you got two nicely seated shoulders and tuck it in there. So, then you can coil embolize as well. After the bifurcation, however, the options are limited. You can't do the open things anymore. You sort of do the endovasculation of the coil, okay? Now we'll move on to SMA and IMA aneurysms. Probably should put the celiac axis above just for intuitiveness, but these are more common, so I did this in ranking of how common they are. So SMA and IMA aneurysms are fairly rare, just like everything here. I mean, to begin with, again, the splanchnic aneurysms were rare to begin with, and now we're in the rare of them. But again, this is 5.5% of splanchnic aneurysms. The IMA is 3.5%, so very small numbers. Majority are mycotic and symptomatic. And you say symptomatic, what kind of symptomatic? Well, symptomatic in that there's disrupted flow to the bowel, and the bowel is very sensitive to disrupted flow, as we know, and so you start getting abdominal pain, kind of this, there's a lot of like postprandial pictures described, and so you can get all this kind of abdominal, sort of this ischemic, mesenteric ischemia kind of picture. Nausea, vomiting, you can do bypasses as well, and I think we'll talk about that elsewhere. Then there's the celiac axis aneurysms. This is fairly rare, so this is now just 5% of the splenic aneurysms associated with infection, trauma, and vascular disease, high rate of dissection. So when it's vascular, interestingly, of all of these, the ones that are most likely to be associated with dissections or caused by dissections, kind of a chronic dissection picture, is in fact the celiac axis aneurysms. Now earlier I said that there's that splenic artery double rupture sign that is almost pathognomonic. This is the other half of it. This is what really makes them completely pathognomonic, or what prevents them from being completely pathognomonic is that when the celiac axis ruptures, it can also do so into the lesser sac, and you get that same picture, which again is the pain as the sac distends, which is relieved when the lesser sac disrupts, or bursts, and then that pain, second onset of pain and hypotension that occurs as the blood starts to fill the peritoneum, and it's very caustic. There's again a high rupture potential. You intervene on all of these that are 1.5 centimeters and above. So even though in the SMA and IMA, you intervene on everything that you see, okay? That's important. Every aneurysm you see, you intervene on the SMA and IMA. But in the case of the celiac axis, there's still a fairly high rupture, but because of the heavy morbidity and just the concerns of accessing the site, you can only intervene on these when they're 1.5 centimeters or above. These do warrant Q3 month evaluations, though, to continue. Usually, in some places, actually advocate a monthly evaluation to then evaluate to see if they enlarge. So we do very tight surveillance on them. And the collateral circulation is often very robust, and as a result, you can often ligate, especially if they're long-standing. There are, of course, open vascular approaches, just like everything, but endovascular is heavily favored here. Finally, we'll end with renal artery aneurysms. The incidence is now, again, very rare, so this is 0.1% to 1% autopsy. The etiology is a fibromuscular dysplasia in some cases, and atherosclerosis in most. So if you listened earlier to the renal artery stenosis lecture, you'll know that atherosclerosis is the #1 cause of renal artery stenosis. And in this case, that accumulation, that buildup can cause intimal disruption and ultimately an aneurysm in these cases as well. Trauma, and then is a third mechanism. There's 70% of these are saccular right at the bifurcation with the aorta. So right when they branch off the aorta, there's a saccular dilation there. That's a kind of an osteal location. Those osteal location ones are very difficult to intervene on. We'll talk about a couple options here. 10% are, notably 10% are bilateral. Essentially, if you've got weakness on one side, you probably have weakness on the other. This is an image of this string of pearls sign, or string of beads sign, which appears, and this is often after endovascular dilation. So who gets endovascularly dilated? Well, oftentimes the patients that get endovascularly dilated without a stent being placed are fibromuscular dysplasia patients. Those patients, they have to periodically get dilated, and as they do, theoretically, it's going to cause some trauma to the intima and whatnot, and you're going to get the string of pearls or string of beads sign. So the majority of these patients with renal artery aneurysms are asymptomatic, which is good because, as I say right here, the #1 sort of symptom is usually a rupture. As you can imagine, there's not a lot of pain because the kidney doesn't really respond that well with ischemic pain, or is not known for its ischemic pain. There may be some loss of function, but probably not. And so thus the symptom that you notice the most is indeed the rupture. So you repair it if it's greater than 2 centimeters on all comers. That's what we just talked about. And then women of childbearing age, or actually childbearding age at this point. I'm not sure. I guess I'm not sure what that is, but 14 years old or something. But no, women of childbearing age are certainly with the intent there at least, and then the 2 centimeters. So remember that 2 centimeter number is really important. 1.5 centimeter in the celiac access group, but otherwise it's 2 centimeters in the renal artery stenosis group, and in the splenic artery group, and in the hepatic artery group, okay? And in the SMA and IMA group, you intervene on all. All right, that's kind of the synopsis we're talking about here. Notably, so what do we do about this renal artery stenosis? We do need to intervene on it. If it's fibromuscular dysplasia, you do a balloon angioplasty alone. No stenting, no nothing, just balloon angioplasty. If it's along a straight part of the artery, which is fairly unusual, then you do an endovascular stent or coil, kind of an old-fashioned, not old-fashioned, but it's just kind of the same thing we talk about, we rehash over and over again. If it's at a branch point, you either sacrifice the branch or you don't sacrifice the branch. If you can remember, most arteries in the kidney are end arteries, so you're not going to get collateral flow. So you either decide if you're going to sacrifice it or not, and if you don't, you have to open up and do an aneurysmorrhaphy or a resection and graft, again, the aneurysmectomy, or you can explant. It's kind of interesting to talk about this, and articles are kind of interesting about this too, but you can explant the kidney, reconstruct on the black table, and then re-implant, or you can just do a nephrectomy. Again, the idea here is that the concern, it's worth a nephrectomy if you really can't do anything else, because when this ruptures, this patient's likely going to die. So the idea is they'd be better off with one kidney than dead, okay? And so that's kind of a wrap. So again, just to recap very, very briefly and quickly, that when you have a splenic artery aneurysm, these are all together called splanchnic artery aneurysms, right? You have a splenic artery aneurysm, intervene when it's 2 centimeters or more, or if the lady is pregnant or of childbearing age. When if it's going down kind of the risk, but I guess we can go anatomic this time. If we do a hepatic artery, 2 centimeters is when you intervene, or if symptomatic. When we do a celiac access, with 1.5 centimeters or greater, and tight monitoring, because it can be devastating, and they can give you that double rupture sign, just like the splenic, or just like the renal artery. I'm sorry, just like the splenic arteries can give you that double bubble sign, or double rupture sign rather. And then as we go down the IMA and SMA, that we intervene on all of those right away. IMA, we intervene on those all right away. And then in between those, if we get the renal artery, the renal arteries involved in the picture here, we intervene on those when it's 2 centimeters, and if sooner, right away, if the patient's pregnant or of childbearing age. All right, that's a wrap. Hopefully helpful, kind of just boiling down the chapter for you. Let me know if you have any questions, and appreciate it.